You're listening to a brief excerpt from Social Determinants of Health, Turning Potential into Actual Value, sponsored by LexisNexis Healthcare, with Aaron Benson, Director Market Planning, and Rich Marino, Director Strategic Solutions. This webinar discusses elements of success for social determinants of health and opportunities for health plans to leverage social determinants of health data to attain quality goals while managing cost and enhancing member experience.
Specifically this afternoon, we want to cover two key objectives. First, we'll examine what is needed to deliver success with social determinants of health. This will include debunking common myths about socioeconomic data and revealing the truth about requiring correlation to health outcomes. We'll also look at previous generations of social determinants of health and what is required for success. Our second objective is we will discuss how social determinants of health innovation can impact quality goals while reducing costs and improving member experience. To do this, we'll look at examples of ways social determinants can enhance predictions as well as impact care coordination. We'll also address the importance of identifying combinations of socioeconomic factors in assessing member risk. A scenario will help bring the discussion to life so you can see how the socioeconomic data can enhance your workflows. So we'll look at 5 myths and truths about social determinants of health data now. The first of our 5 myths is that socioeconomic data is just more noise in an already data-overloaded world. While it's true that in the age of big data, it's easy to become overwhelmed with the sheer amount and variety of data available on members, socioeconomic data is one of those key pieces of data that really should rise to the top. You've probably seen studies that show that medical care determines only about 20% of overall health, while social, economic, and environmental factors determine 50% of overall health. This means to effectively achieve better health outcomes for members, payers really can't afford to ignore 50% of what determines their members' overall health. In addition to being very valuable data, the socioeconomic data can actually make member risk assessment more efficient and less time-consuming. Innovative payers we're seeing are already determining ways to incorporate this data into their predictive modeling and care management programs. With social determinants of health data, payers can design better care management programs to meet the needs of their members. This means more accurately identifying high-risk members can help payers to become more effective and efficient by allocating limited resources to support the members most in need. Our second myth is that all data about a person and their life outside of their medical claims relates to their social determinants of health. The truth is that while data may be useful in some capacity, not every piece of data on a person is a social determinant of health. There are endless ways, as I'm sure you know, of receiving data on individuals, including basic demographic data, survey data, marketing data, and more. But a lot of it has really limited potential for improving predictive accuracy or identifying hidden risks. The key to addressing social determinants is to identify a source of data that's continually updated, provided in a consistent format based on reliable sources such as public records, and contains data that's been clinically validated to predict healthcare outcomes. Rich will talk about that more with us soon. Clinically validating attributes is critical to successful predictive analytics because some attributes don't correlate strongly to health outcomes. That really is where you're seeing the noise. In an analysis of over 560 attributes by our data science team, 442 were found to correlate with key health outcomes like readmission, medication adherence, hospitalizations, and overall health costs. And even when attributes are clinically validated, we've found that different attributes correlate to different outcomes with different accuracy strengths. So knowing correlations allows you to use data to enhance predictive power so you can improve risk stratification efforts. The third myth I hear is that examining only individual socioeconomic attributes about a person will allow you to make accurate predictions about a member's overall health risk. The truth is, focusing on an individual's attributes rather than the combined picture is really misleading. I like to think of the analogy that it would be like eating a cake where you eat the individual ingredients of a cake and expect them to taste the same as the cake itself. The results are very different. When you're predicting risk and personalizing care management, it's crucial to view a person holistically across multiple categories of social determinants, which range from social and community context to neighborhood and built environment and education and more. Any attribute on its own is helpful, but not enough to develop an accurate risk understanding because you really want to look at the complete picture about an individual. For example, It's commonly known that low income can correlate with poorer health outcomes. However, the additional knowledge that the member is in college may indicate that the low income is temporary. That member may actually end up being more likely to attain a better health outcome because education often leads to better career opportunities and a higher future income. The fourth myth is the one that I hear the most often, and that is that aggregated data at the zip code or census level can be used to personalize care for a member. For market expansion and resource allocation decisions, looking at aggregated level can be useful. But for personalizing care management, hundreds of attributes need to be considered when determining an individual's health risk. Within a single zip code, it's not unusual to see variance in income levels, crime rates, and other factors impacting an individual's neighborhood and built environment. If I think about the city where I live in Atlanta, you see a lot of change if you just walk a few blocks over. This is why it's important to look at an individual's specific address. Further, focusing on zip code alone ignores the influences of education, economic stability, and social and community context. So if I go back to my previous cake analogy, it's only one of many ingredients you'd need to bake a cake. Getting data across various categories of social determinants at the individual member level allows care providers to see that comprehensive view of a member and create a more comprehensive plan of care outreach. And then finally, our fifth of the myths, and our final one, is that we will discuss that socioeconomic data is only useful in combination with clinical data. The truth is that adding socioeconomic data to clinical data can help payers to personalize care and more accurately predict risk. But even in the absence of that clinical data, using only socioeconomic data has proven to be useful. In fact, it can more accurately predict risk based on total cost than traditional age and gender predictions alone. And we've shown that it can improve the accuracy of predicting readmission likelihood, even compared to certain clinical data models. Even small lifts of 1% or 2% in accuracy over traditional predictions can lead to really big impacts. So using socioeconomic scores to more accurately identify high-risk members who account for the majority of healthcare costs and then proactively address their care can lead to 10 to 20% savings over using traditional predictive models alone. I hope that the key takeaway you have from listening to these myths is that socioeconomic data is a vital force for healthcare risk prediction and the improvement of care management, but it's got to be the right data.
You've been listening to a brief excerpt from the Social Determinants of Health, Turning Potential into Actual Value webinar, sponsored by LexisNexis Healthcare, recorded on April 18th. The full interactive webinar with audience polling and Q&A discussions explores why previous generations of SDOH failed, offers examples of how the right data correlates to health outcomes, and identifies examples of how SDOH innovation can impact quality goals while reducing costs and improving member experience. You'll want to be sure to watch the full 1-hour webinar video, now available on YouTube, at the link indicated on your screen.